great honor for me to present you the next speaker, Dr. Greco from Rome, Italy, combo treatment. The combination is a big topic in Italy. As you know, it's worldwide the best, the combination you can have, the combination of Italian wine and food. And now
Yes.
the topic is combo treatment. Watch carefully the lecture, combo treatment. Thank you, Alessandro.
Thank you. Thank you so much. Thank you so much, Mr. Chairman. Good morning, dear colleagues. It's a pleasure for me and an honor to be here with you today to share my experience with the Invisalign technique and in the combination treatment of not Italian food and wine, but probably something else that we will see, but it's very fun. We are living at an exciting time. We are moving from traditional orthodontics to digital orthodontics. In everyday life, in everyday practice, we see new technologies coming every day. And with the introduction of the new intraoral scanner, we are completing the full digital workflow in our practice. And using an image shown by one of the most brilliant minds of our century, which was Steve Jobs, I think we are probably in this moment at the crossroad between technology and liberal arts. Well, liberal arts are defined as the intellectual activity that we should use approaching our treatments. And probably we know we have a lot of softwares coming, and we saw yesterday and today, in particular yesterday, a lot of beautiful softwares that can help us in doing more precise diagnosis, more precise treatment plan. We can do a digital setup with many softwares. We can analyze in a 3D world our movements. And above all, we are the European Aligner Society, so we use customized appliances that we can have from this software. But please keep in mind, this is very important, there should be a mind behind all this process. There should be the orthodontist doing and selecting the movement that we want to achieve with our treatment. And to do that, the orthodontist should probably totally shift paradigm, moving from a reactive model to a proactive model, as stated in this beautiful book chapter from Rohit Sachdeva, which is the inventor of the SmILE system. And when we are talking about reactive model, we do every day. We have a mental plan with traditional orthodontics appliances. We just use standard appliances, which should be standard for each patient. We just react appointment by appointment to what happened in our everyday practice during our treatment, and we just trying to contrast collateral effects that we experience during treatment. And above all, we know from literature that we have some limitation in what is manufacturing brackets and wire precision. So when we apply a proactive model, it's totally different because we don't need a mental plan. We have a digital plan of each step of our treatment. We can just use customized appliances individually fabricated for each patient, and we are helped and guided by the system. And above all, we can prevent, because we know biomechanics, and so we can prevent collateral effects during the plan of our digital plan in an environment trying to respect the biomechanics of what we prescribe in our digital setup. And one other important thing is that our intellectual activity should be guided and should be led by evidence-based dentistry. We know we have a beautiful sentence published in an editorial of Vincent Cockins about the evidence, or what evidence-based is. So it's very important for us to apply this conscious, explicit, and judicious use of current best evidence when making a decision about the care of a patient. And we have also to keep in mind that another important thing on what we do is patient-centered care. We have to take in consideration what patient asks to us, so it's really important. And going through literature, and we saw in this today a lot of beautiful, interesting lectures, we know very well that with Invisalign technique in particular, there is some effective movements that we can achieve with the aligner, and some more complex movement that we cannot achieve with aligner. So probably what in terms of combination, what we can find is just trying to combine what we do with traditional biomechanics with our digital setup, with our digital plan. And in my experience, I just trying to divide in three big groups all this combo treatment. One is in case of vertical discrepancies. We see a lot of open bite treatment yesterday. In the extraction treatment, which is quite a complex with the liner, and in what I define the hostile movements, because we saw yesterday some beautiful lecture from Dr. Williams about the use of TADs combined with the liner. So let's start with the vertical discrepancy, which is very common. I like very much to combine this kind of problem with TAD, because when we have to face this problem with anterior and lateral open bite, and when we have this phase with long phase and gamma smile, and when we have these numbers with this kind of skeletal phase, we have some problem of severe hyperdivergent pattern. We have probably to ask if alignment could be sufficient just to correct what we want to correct. We have 41, as you can see, degrees of divergency, so it's very severe case. We can apply probably with a surgery case, but if patient refuse, as often happen, we have to imagine something different. So in a case like this, we can probably enhance the vertical movement of posterior teeth, of the intrusion of posterior segments, by simply apply a TAD between the roots of the first and second molar to plan on our digital setup just a simple cutout between on first and second molar, and just bond a sectional on first and second molar and apply an I-tie called spring, exerting more or less 150 grams of force, and we can achieve the intrusion of the molar in a predictable way, probably in a more predictable way. This is what happens when we start our treatment. We just, on our digital plan, in our setup, in our clean check, just plan to align teeth and control the vertical movement of intrusion of posterior teeth, and you see what happened after some months, and you see what happened at the end of the treatment. We totally correct the lateral and frontal open bite. And if you take a look at the number, which is very important in our practice, and we learn a lot when we do the superimposition between before and after, we can see how it works. You can manage on the red line the intrusion of the molar, and you can see how it changed the divergency from 41 to 38. So we were successful in managing severe vertical discrepancies like this. But probably one of the most interesting topic that we can find also in literature is based on the extraction treatment. You know very well that now we have a new protocol, a G6 protocol for Invisalign for the extraction, but it just limited of the extraction of the first premolars. But before this, in my experience, I tried just to combine fixed with Invisalign. But we have to start at the beginning, because sometimes we can have some favorable condition based on the analysis of the long axis of the teeth, and so we can probably don't need anything else than the aligner, as you see in the favorable condition in the upper picture. But sometimes we can have some unfavorable condition, and unfavorable conditions are influenced by the root inclination, by the apex position of the teeth, mesial and distal to the extraction site, and obviously by the anchorage condition. So when we're facing an unfavorable condition, we have to invent something. We have to try to manage this problem. And so in my experience, I decided to use a precise, customized cutout on the lingual surface of the molar and premolar and canine to just to bond one lingual braces on the canine and two mini molar tubes on the premolar and on the molar, and just use a fixed sectional, as you see in this picture. The first one is a squared Y, and the second one is a rectangular Y, just trying to control the root movement, the tipping, without applying any kind of class 1 forces, no elastics, nothing, just the control of the movement. The crown tipping and the crown inclination and the force will be delivered by the aligner, while the fixed sectional that you see, is useful only for control of the roots and no more. So let's see how it works in a case of severe protrusion, of severe class 2, where we need to where we need to treat the face of this patient, for example, with an exaggerated overjet, and we see also his numbers in his skeleton, and you can see it's very difficult for us to manage a huge overjet like this, because obviously we have to extract. And in our digital plan, we decided to extract one first premolar on the right and one second premolar on the left, simply because it was missed, it was delayed, to be honest. It's not a question of choice. There was just a delay on that second premolar. And this is what we planned on our digital setup. And just to reach this, we decided to apply this new kind of approach with a customized cutout. You see the lingual braces in the upper arch, and you see how the treatment is going, trying to close. You see the inclination of the roots on the right and on the left side in an unfavorable condition. And you see at the end of the treatment, how can we manage with a perfect class 1 occlusion of the canine and a second class 2 molar relationship, obviously in this case due to the extraction of only in the upper arch. And if you take a look at the numbers, we see how changed totally the profile of the patient. It was totally corrected with a normal and proper overjet and overbite. And if you take a look at the superimposition, we see on the red and the black line how changed totally the profile and the inclination of the incisor in a predictable way. And this is what we want, to treat our patient with high level of predictability. In particular, and I was very interested yesterday by the presentation of Dr. Wilms about the use of TATs. We can use TATs combining, obviously, with Invisalign, with the line technique. And I think in my practice, it's very common that patients ask me for a kind of treatment, a conservative kind of treatment, trying to avoid to put implant in a mutilated dentition or to reduce the number of implants. So when we face a case like this with a mutilated dentition with many teeth that is missing, and you see also in the X-rays what happened, we have to do a treatment plan as shown by Raman, together with our general practitioner, with our surgeon, with our implantologist. So we have to define what to do. And obviously what to do is also related to what patient ask to us. And in a case like this, we decided to extract 2 upper premolars just to correct the class 2. And we decided to close the space in the lower part of the arch and to reduce the space in the lower left part of the mandible, just to reduce the number of implants at just 1. And to do that, we have, obviously, this is a very difficult movement is very difficult and hostile, I will define movement. This is our digital setup on the CleanCheck. So we decided to extract premolars. One was just the root of the second premolar on the right side. We decided to extract the first premolar on the left side. And you see what happened in our digital plan, just trying to reduce the space just for 1 implant on the left side of the mandible. And it's very difficult to achieve this movement, obviously, because it's biomechanically complicated to obtain. So we need something different. And we planned something different. We just planned a customized cutout, as you can see here, just to apply a sectional, fixed sectional, or with mini tubes and a 0.16 per 0.22 wires, stainless steel. And obviously, we need a TAD, an anchorage that can just combine the mesial movement of the molars with a power arm, obviously, to apply our biomechanics more close to the center of resistance of the tooth. So this is the system, and we have just to wait, because obviously this is the system not applied with an elastics, but just with an high-tie cold spring that works for us. So we have just to be sure that the application, the sectional wire maintain its stability, its stiffness, and then we just wait for the space to close. And that's what happened. And we can combine this, obviously, with micro-osteoperforation. You know, is the next frontier, probably, or we talked a lot about yesterday and today about acceleration. And, you know, one beautiful approach is that of Dr. Ojim about acceleradent. Another option is just to do some micro-osteoperforation to simulate something similar to the coarctation, to, in a case like this, not to accelerate, but to simplify the movement, because we are talking about a really hostile movement. So this is what happened quite at the end, before the refinement of our case. And what we can see here is what happened also on the X-rays from the beginning, when we see a class 2 occlusion and a big space in the lower arch, and what happened in the state, in the pre-refinement stage. We reduced the space, and with a quite good parallels between the second molar and the premolar. So, going to my conclusion, I will say that it's very important for me in a combo treatment because it's very important to increase predictability of what we do. We have to deliver care to the patient, so we have to be safe and sure what we give to our patient. In the second, we have to improve in extraction case at the root control, because we know very well that with the liner it's not so easy to take the right root parallelism at the end of the treatment. And above all, you know very well, and we saw yesterday, there is a lot of movement that we can achieve in a vertical dimension by means of the liner, but sometimes we need to enhance the liner biomechanics. So it's very important that we can just plan our treatment in a proactive model, as I said before at the beginning. I will just give you my take-home message through the words of the most important Austrian painter, Gustav Klimt, who said that every portion of life, however small and insignificant, may always leave space for artistic inspiration. I thank you so much for your kind attention.